So today we are going to talk about the various immunosuppressant drugs. So the immunosuppressant drugs are the agents that block lymphocyte activation and its proliferation. So what happens that after it blocking the lymphocyte activation and proliferation, it reduces the acute transplant rejection by suppressing the cellular immunity. So it is also used in the prophylaxis to prevent the transplant rejection. So it is frequently combined to achieve greater efficacy with decrease of toxicity. So various immunosuppressant drugs are combined together, but you have to take in mind that the chronic suppression of the immune which usually leads to increased risks of infection and malignancy. So today in this video I am going to talk about various immunosuppression drug. We'll talk about their classification, and we'll also talk about their mechanism of action, indications, toxicity, and various remarks related to the drugs. So first of all, I'll discuss in brief about the classification of the immunosuppressant drug. The first, there is calcineurin inhibitor, which specifically inhibits the T cell. So those are cyclosporin and tacrolimus. There is the mTOR receptor inhibitors. Those are sirolimus and everolimus. The anti-proliferative drugs are azathioprine, methotrexate, cyclophosphamide, and mycophenolate mofetil. The glucocorticoids are the prednisolone and other glucocorticoids. There are various biological agents, but today we are going to discuss only about the interleukin 2 receptor antagonist basilizumab. So other biological agents are tumor necrosis factor alpha inhibitor etanercept, infliximab, and adalimumab. Interleukin 1 receptor antagonist anakinra, anti-CD3 antibody muromonab's CD3, the polyclonal antibody antithymocyte antibody, and RHOD immunoglobulin are the polyclonal antibody. So we are going to discuss their mechanism of action, their indication, their toxicity, and the remarks related to the drugs. So first, calcineurin inhibitors. The calcineurin inhibitors are the specific T cells inhibitor. Those are the cyclosporin and tacrolimus. First of all, let us talk about the cyclosporin. The main mechanism action of the cyclosporin is that it is calcineurin inhibitor. It's bind cyclophilin, which blocks the T cell activation by preventing the interleukin 2 transcription. So the indications of the cyclosporin are psoriasis and rheumatoid arthritis. The toxicity of the cyclosporin will be the nephrotoxicity. The main toxicity is the nephrotoxicity. It is the nephrotoxic. And other toxicity are the hypertension, hyperlipidemia, neurotoxicity, gingival hyperplasia, and hirsutism. Now let us talk about the tacrolimus. The tacrolimus is also the calcineurin inhibitor. So it binds FK506 binding protein, FKBP, which blocks the T cell activation by preventing the interleukin 2 transcription. So the toxicity are similar to the cyclosporin, but there is increased risk of diabetes and neurotoxicity. There is no gingival hyperplasia or hirsutism in the tacrolimus. So both are calcineurin inhibitors. So I want to give a note on both cyclosporin and tacrolimus is that both calcineurin inhibitors, both cyclosporin and tacrolimus, are the highly nephrotoxic, specifically in the higher dose or in the patient with decreased renal function. So while giving the cyclosporin or tacrolimus with the patient with impaired renal function or in higher dose, you have to always send the renal function test. So renal function test should always be ensured while giving in higher dose, or the patient who have impaired renal function shouldn't be prescribed cyclosporin or tacrolimus. Now let us discuss about the mTOR inhibitors. The mTOR inhibitors are the sirolimus and everolimus. So sirolimus, the main mechanism of action of sirolimus is it is the mTOR inhibitor. It binds the FKBP, which blocks the T cell activation and B cell differentiation by preventing response to the interleukin 2. So the indications of the sirolimus is that it is used in the kidney transplant rejection prophylaxis, specifically So during the kidney transplant, this sirolimus drug is used. Now let's talk about the toxicity of the sirolimus. The sirolimus toxicity has mainly the pancytopenia, insulin resistant, and hyperlipidemia. The sirolimus is not nephrotoxic. It is not nephrotoxic. Sirolimus is not nephrotoxic. So on the note of the sirolimus, you have to know is that it is synergic with the cyclosporine. So when given with the cyclosporine, when the sirolimus is given with the cyclosporine, the drug has a synergistic action. Now let us discuss about the antiproliferative drugs. In the antiproliferative drugs, they are azathioprine, methotrexate, cyclophosphamide, and mycophenolate mofetil. Now first of all, let us talk about the azathioprine. The azathioprine is the antimetabolite precursor of the 6-mercaptopurine. It inhibits the lymphocyte proliferation by blocking the nucleotide synthesis. The main indications of the azathioprine is that it is used in the rheumatoid arthritis, Crohn's disease, glomerulonephritis, and other autoimmune conditions. So the toxicity of the azathioprine will lead to pancytopenia. On the note I want to discuss about the azathioprine is that 6-mercaptopurine is degraded by the xanthine oxidase. So the toxicity will be increased by the allopurinol if it is given with the azathioprine. So azathioprine and allopurinol should not be used together. Now let us discuss about the mycophenolate mofetil. The mechanism of action of mycophenolate mofetil is that it reversibly inhibits the IMP dehydrogenase, which prevent the purine synthesis of both B and T cells. So the indication of the mycophenolate mofetil is that it is used in the lupus nephritis. The main toxicity of the mycophenolate mofetil will lead to GI upset, pancytopenia, hypertension, hyperglycemia. It is less nephrotoxic and less neurotoxic. So the mycophenolate mofetil is often associated with the invasive cytomegalovirus infection. Now let us talk about the glucocorticoid, which is the prednisolone. So the glucocorticoid inhibits the necrosis factor kappa B, which suppresses both B and T cell function by decreasing the transcription of the many cytokines, which induces the T cell apoptosis. So the indication of the glucocorticoids are many autoimmune and inflammatory disorders and adrenal insufficiency and asthma-like condition, the CLL and the non-Hodgkin lymphoma. The toxicity, if it is used in excess, what are the various side effects we see in the glucocorticoids? We see the Cushing syndromes, osteoporosis, hyperglycemia, diabetes, amenorrhea, adrenocortical atrophy, peptic ulcer, psychosis, the cataract, and the avascular necrosis. We see that. So on the note, while giving the glucocorticoid, you should know that the demargination of the WBC causes the artificial leukocytosis. Adrenal insufficiency may develop if drug is stopped abruptly after the chronic use. So you should always stop the glucocorticoid in the tapering dose. So you should not stop the glucocorticoid abruptly if it is used in longer period, more than 14 days. So the glucocorticoid, if we want to stop the drug after the prolonged use in the patient, we should always stop it by tapering the glucocorticoid. Now let us discuss about the drug interleukin-2 receptor antagonist basilizumab. The basilizumab is the monoclonal antibody that blocks the interleukin-2 receptor. So the main toxicity of this drug is edema, hypertension, and tremor. So other biological agent and the antibodies we will discuss in the next video. So I hope you understood these various immunosuppressant drugs. So I hope you understood their mechanism of action, indication, toxicity, and remarks related to those type of drugs. Again, I am going to revise some of the important immunosuppressant drug that you should know. First of all, calcineurin inhibitor, those are cyclosporine and tacrolimus. The mTOR inhibitor, which are sirolimus. The antiproliferative drug, that is azathioprine and mycophenolate mofetil. The glucocorticoid, it is the prednisolone. And the interleukin-2 receptor antagonist, that is basilizumab, that you must know. So I hope you understood this topic on the immunosuppressant drugs. Thank you.